Thank you so much for joining us for our first lecture regarding the point of care ultrasound for vascular scanning. So we're going to start out with just some of the basics that are going to make you comfortable in your scanning, understand why we need to follow the rules we have to follow in order to get accurate information, and get you off on the right foot to get started in your scanning your patients. So objectives for today, we're going to compare the various kinds of flow encountered in blood circulation, identify how a stenosis will affect flow and why, define and discuss the Doppler effect, Doppler shift, and the Doppler angle, and compare Doppler shift and Doppler power displays as well as spectral analysis, while discussing how spectral analysis can help identify upstream and downstream conditions in your patient that you may not otherwise appreciate. So first of all, we have to look at the circulatory system, which as providers, you're all very familiar with. And we know that under the right circumstances, including the appropriate conditions, the patient state, as well as your experience utilizing ultrasound, we can often detect thrombus, stenosis, and changes in resistance at the tissue bed level. Doppler ultrasound can detect flow and other types of motion, so it's important that we remember while Doppler is going to be utilized mostly, if our intent to look at the flow of blood, because of the physics within the ultrasound machine, we actually pick up tissue movement and different things like that with Doppler too. So there are some strategies that we can use to help eliminate that when it's degrading our image. So first of all, we're going to look at just how fluids act, and by understanding how fluids act, we can understand more clearly how blood flow is going to act. So fluids in general are classified into gases, liquids, and solids, with gases and liquids being the two types of fluid, in that they will just fulfill any container that they are placed in. So one consideration about how fluids interact within the body is going to be viscosity. So like here you see that we have the viscosity of water. We've all experienced the difference between the viscosity of water or the viscosity of something like honey or molasses. So the more viscosity that a material has, the slower it is going to flow. And that's going to have a bit of a impact on how we see blood moving through the system. Now, really, there is about a 5 times greater viscosity in blood than there is in water. However, it really doesn't play that big of an impact on the velocities that we see. So it's something to be aware of, but not something that's going to affect us significantly. When you see a patient that has blood viscosity that can vary because either they have anemia, that's going to drop their viscosity, or maybe they have polycythemia, that's going to increase their viscosity. As they get the higher hematocrits, that's going to increase the viscosity. But again, these are relatively negligible, and so we don't really pay that close of attention on this. It's just something to be aware of. What really is going to affect our scanning is going to be the pressure. So we know that we don't get flow without pressure. So there has to be a driving force behind a fluid in order to get flow. They can describe that force with as force per unit area. So when we're looking at the blood flow in a patient, we can talk about their flow rate or how much force per area there is moving that blood flow through the system. Obviously, the higher the pressure, the higher the force, the higher the blood flow is going to be. When we our blood pressure or our blood motion is typically controlled by either hydrostatic pressure, which is the force of gravity on fluid. So that's really going to affect more our venous system, whereas the heart on the arterial side is going to cause kinetic energy, force of pressure, resulting in the blood flow. So a pressure difference is required in order for flow to occur. We also know that in this flow system, friction is going to have a significant impact. So we're going to look at how some friction can affect the flow as well. The greater the pressure, the greater the flow rate is going to be. So that's why in our arterial system, obviously, we're going to see the maximum flow rate at the peak of systole, and then the minimum flow rate in diastole. We can go through some fancy calculations and calculate the pressure gradient, but as you've all experienced, even if you've ever held a PVC pipe or a hose, you know that the pressure gradient is going to cause a change in motion. Now, on the venous end, when we talk about pressure gradient, we know that our right atria is considered our 0 point of pressure. So if we have a standing patient and we're trying to evaluate their venous flow from, say, the calf up to the right atria of the heart, they're going to have a pressure. And that pressure, because we don't have a pump on the venous side, that pressure is usually acted upon by something called like the calf pump. So every time we flex our calf, that's going to contract, that can squeeze a vein, and that can cause that forward motion of flow. On the other hand, if we have a patient that is completing a Valsalva maneuver, otherwise maybe they would be getting some flow up to their abdominal and then thoracic area back to that 0 point right atrium, but if in the case of Valsalva, we're increasing that abdominal pressure so much, it's going to cut off venous flow. So we can use some of these types of maneuvers in order to check the flow and see if we have open veins or if maybe we have occlusion through thrombus or something like that. On the arterial side, we're looking a lot more at volumetric flow rate, or Q, or the overall just flow. So the volumetric flow rate is the volume of blood passing a point per unit of time. So if you look at this example here on the right, what we're doing here is you can see this little cursor, and that is going to be right where we're taking a sample here. And when we have this little cursor, we have some control over this cursor, and we're going to talk about how you utilize that. But basically what our system is doing is it's going to be detecting the flow right at that spot in between those two cursor lines and calculating the flow in that particular area over a unit of time. So again, we have a formula for that, and you can see how flow is going to be caused by the change in pressure. So if we have an increased change in pressure, we're going to increase the flow. But on the other end, it's going to be decreased by resistance. So anything that's providing resistance, which typically is going to be friction in our vascular system, or arterial constriction, that is both going to lower the flow. So we have a direct relationship here where we increase our pressure, we increase our flow, but if we increase our resistance, we have an indirect relationship. So if we increase our resistance, then we're going to decrease our flow. We talk about the vascular system as if it were in long straight tubes, but we know that that's actually not the case. So a lot of the calculations and the formulas that we use are based off of sort of this inaccurate idea. However, it's really the best laws that we have to go by, and they come out relatively accurate, but again, they're not perfect because our vascular system is most certainly not long straight tubes. The overall adult blood flow rate, or cardiac output, so the blood exiting that heart into the aorta, is going to be about 5,000 milliliters per minute in an adult. How that blood flow moves through the body after that, after it exits the heart, is going to be dependent a lot on resistance. So again, we're talking about flow resistance in long straight tubes, even though that's mildly inaccurate, but it's not just the tubes that control the flow. It's also going to be dependent on the fluid viscosity. So obviously, thicker fluid is going to have more friction. So the more friction, the lower the flow. The more loss there is from that kinetic, or that energy of motion, into a thermal energy caused by friction. It can also be affected by tube length. So the longer the tube, if you think about it, the longer the walls would be. The longer the walls would be, the more interactions those little blood cells are going to have with the walls, and that's going to cause an increase in friction, which results in an increase in resistance, or a transfer of that kinetic energy to thermal energy. And then finally, the radius. The larger our radius, the less friction we're going to have with the walls, because a less percentage or ratio of those cells would be interacting with the wall. So that larger radius, or larger diameter, is going to have a decrease in friction, which would cause a decrease in resistance. Now, if we look at how all of these, the length of the vessel, the viscosity of the vessel, and the radius, how they all affect it, the one that is going to have the most significant effect is going to be the radius. So one of the laws that we talk about a lot when we're talking about vascular ultrasound is Pucel's law. And when I'm teaching the sonography students about Pucel's law, I relate this to a pipe. So P is for Pucel, P is for pipe. So all the qualities that Pucel's law describes really relate to your basic PVC pipe. So, so when we talk about Pucel's law, it's the way to calculate flow in long straight tubes like a PVC pipe. Because again, we are not made of long straight tubes. This is more of an approximation in our vascular system than an actual precise description. So Pucel's law describes how pressure changes, resistance, viscosity, and length of the tube can affect the flow. Most of these changes, like I mentioned, are due to friction. So when we look at flow, if we have an increase in the pressure change, like we said, we'll have an increase in flow. If we have an increase in resistance, we'll have a decrease in flow. But what causes that change in resistance? That is where we're going to add into our calculations how viscosity and radius and length all contribute to that increase in resistance. So we have this, this basic equation, which you won't have to do, but it just kind of demonstrates where this all comes in. So if you look at the length, it's accounted for here in our equation. Viscosity is accounted for here, but radius is accounted for as an inverse quantity in this description, and it's raised to the 4th power. So even in this equation, you can appreciate that radius is going to have a much more significant impact on resistance than it would than viscosity and length would. And if they put this all together and we look at how resistance is calculated in the flow equation, you can see that if we have a change in pressure, which is needed for motion, we multiply that by pi times diameter to the 4th, divide it by 128 times the length times the viscosity. That will give us the overall flow. Now we're very fortunate now in that our computer system is doing this behind the scenes as we take our measurements. But it's important to really kind of think about these different characteristics and how they're going to affect your flow. So if you're seeing a change in your flow, that you understand that a decrease in flow could be due to radius decrease, viscosity increase, or length increase. The most common of those obviously being the radius increase, or excuse me, radius decrease when we experience a stenosis. So the blood flow in the body can be described in a few different terms. So resistance, most of the resistance in the body is not actually caused by length or viscosity changes. They're caused by that radius change. And that radius change is typically or normally controlled with arterial constriction. So as you know, as my hands, as I'm getting cold, I'm going to have some arterial constriction, allowing less blood flow to my hands and really maintaining more of that blood flow to my internal organs. That arterial constriction is going to cause a reduction in diameter or radius of the vessel, which is going to then make it higher resistance. Those resistance changes can produce some very dramatic changes in flow resistance. An example of where you might see this is if I took somebody that was, you know, bedridden at rest, and I went and I scanned an arterial of their lower extremity, because muscles that are at low, low output, low workforce at the moment, they're going to have quite a bit of arterial constriction. And so I would see a high resistance to flow when I looked at the blood flow going to those tissues. However, if I got up, had them get up, run 5 minutes on a treadmill, and then re-evaluated, because the blood flow requirements to those muscles would have been so dramatically increased, those arterioles are going to go ahead and relax, allowing more blood flow to the muscles, and I would see a very significant change in how the blood is moving in that area because of that arterial constriction, the increase in the radius, the dilatation of those vessels, and that would change how I see the blood acting in the body. We can also divide flow into 5 spatial categories, just describing exactly how the flow looks. So the easiest type of flow to describe is really plug flow. So plug flow is going to occur, we can see it kind of up here in our first example, where plug flow will usually occur at the beginning portion of a new vessel. So let's say as my blood flow comes from my aorta and goes into, let's say, bifurcates into my common iliac. As it does this, it's starting out in a new vessel, and it's all going to be moving in what we would say a frictionless flow, laminar flow. So it would be like a laminated countertop where you have straight laminated layers flowing in a parallel manner. So our plug flow would be flowing in this parallel manner, meaning that it's laminar. They're not bumping into each other, running into things. They're just nice and smoothly flowing one layer over the next. Now, if this laminar flow is also traveling all at the same speed, then we would refer to it as plug flow. It's moving like the plug of a syringe through the vessel. Now, as this travels farther and farther down the vessel, friction is going to start to impact the peripheral cells, and they're going to start to lose some of their kinetic energy to friction, turning it into thermal energy, and they're going to slow down while the central cells are going to continue to move faster. And so in this case, we are going to call this parabolic flow. It's still laminar. They're all sliding together in parallel lines, but now instead of having them all move at exactly the same speed, we're going to have increased velocity in the center with a little decreased velocity in the periphery because of that friction. And again, that is called our parabolic flow. So here we've talked about our plug flow. That's going to be laminar, but all moving at the same speed. Laminar flow just is describing that they're all going parallel to each other, and then parabolic is still in laminar, but the central portion of the blood is flowing faster than the peripheral flow. That is going to help us predict why and where we need to place our little sample that we talked about on that first couple slides. The next is our disturbed flow. So disturbed flow is going to occur when we have a bifurcation or even a stenosis like we have here in A. And it disturbs or disrupts the lines of the flow. They can no longer maintain in exactly straight lines. However, the disruption is insignificant enough that they all shift, but they don't start to run into each other. So with disturbed flow, you're still maintaining laminar flow. You're just disturbing the path slightly. Now, we're going to talk about turbulence here on the next slide, but turbulence is when you have enough disruption that you no longer have that laminar form. Okay, so here's an example of turbulent flow. So turbulent flow is when we have lost that laminar parallel orientation, and now we are getting cells that are turbulent, just like we see here in this waterfall. Here we have nice laminar waterfall flow. When it hits the bottom of that waterfall, all of a sudden those water molecules are going to start turning and running into each other in this very irregular pattern. Well, the same type of thing is going to happen in our vascular system. So this example that we see down here, we had a plug flow. Everything's going the same speed. It's all laminar. And as it moved through the vessel, friction took a toll on the peripheral cells. Those in the center started going faster. So now we have parabolic laminar. But as we get into a much larger space, they are going to start to diverge and eddy and roll around in this larger space. And so that's when we see turbulence. We often see this turbulence. We're going to be identifying it in our arterial side post-stenosis. So if we had a big narrowing stenosis like you kind of can see in here, this narrowed area, and then it gets released out into a larger area, you're going to see turbulence occur right in this space. Okay, so now we'll just talk a little bit about our arterial flow. So most of the time, our pulsatile flow will be on the arterial side. Now, We can see a little bit of pulsatility in our venous flow as we're getting up towards the right atrium. So if we're looking at the SVC or the IVC as it's just about to enter the right atrium, or even those hepatic veins right before they dump into that very proximal IVC, sometimes we'll see a little bit of pulsatility to our flow. That is because basically of reverberation from the heart. So with that, we don't really worry too much unless it's significant about a bit of pulsatile flow in the venous system. But for the majority of the time, we're really expecting our pulsatile flow to be only on the arterial side. So with pulsatile flow, we're going to see acceleration and deceleration over the cardiac cycle. So as your heart, sorry, my heart's ugly here, but let's say as my heart goes into systole, it is going to be ejecting the blood from that left ventricle out into the aorta. And as that happens, those cells are going to move forward very quickly. That correlates, if I look at what we have here as a spectral Doppler, that correlates to this portion of my spectral Doppler form where we see forward motion very quickly. At the end of systole, my heart starts to relax. And as my heart starts to relax, that pressure moving the blood forward starts to subside, and we see the forward motion of those cells start to slow down. Now, in this particular waveform here, there's something, there's arterial constriction, or there's some resistance in the bed that when there's nothing pushing those cells forward, they're actually going to move backwards. So it pushed all the way through systole. As the heart starts to relax, something up ahead pushes back hard enough that the blood actually moves back a touch. And so we call this early diastolic reversal. That blood is reversing in the system. Then you see in later diastole, this region here, the blood is going to have forward motion again. Now, the reason it's getting forward motion in this case is because of the Windkessel effect, which we're going to talk about in a moment. But it's basically almost like a recoil of the vessels that will give another little push to that blood flow in the arterial system to move it forward one more time before systole kicks in again. So that's what we're looking at here during our pulsatility of an arterial flow. So this would be your systole, this would be your early diastole, and this would be your late diastole. And we're always going to be looking at those 1, 2, 3 components in order to kind of predict what the blood flow is doing. Now, if I were to see this waveform in something like a resting leg muscle, I wouldn't be concerned because it should have arterial constriction. It should have a lot of pressure pushing back. If I were to see this to the ovary or to the testicle or really any of my abdominal organs that have a high need for blood flow constantly, I would be very concerned here. So if I had a very low resistance waveform, or a very low resistance organ, like say the liver or kidneys, when I had systole, I would see forward motion during systole. Early diastole, I would still see that drop, but there would be no resistance up ahead. So even during diastole, I'd get allowed forward motion, granted at a much lower velocity, but forward motion nonetheless all the way till the next systole. End of systole, it stops that or reduces that forward motion, but because that organ wants the blood so much, it's going to have those arterial dilatation, which is going to allow it just to kind of flow through with the motion it already has because of that very low resistance. Okay, so when I'm looking at a waveform in the vascular system, either arterial or venous, what I'm really doing is looking for what's happening at the site, exactly where I have my sample set at, but I'm also looking at indicators what's happening before blood gets to that sample and what's happening after blood gets to that sample. And a lot of what I see in my waveform can help me determine that. So When we're talking about on the pulsatility of the blood flow, it is going to depend on pressure. So if I have a patient that has very poor heart function, they have a very low ejection fraction, my pressure during systole is going to be diminished. So I'm going to see changes there. So pressure is going to increase, or predict what my waveform is going to look like. The other thing that could happen is if I had a great looking vessel and then it got very stenotic and then returned to normal size, obviously I wouldn't be able to squeeze enough blood flow through that stenotic area to maintain this pressure in this area. So I would again have diminished pressure, and I would see something that looks more like what we call a tardus parvis waveform, where I wouldn't get this fast systolic upstroke, this one. I would get a very low, slow upstroke, and that would be because of that pressure pushing the blood flow. So pressure is going to be really important. It's going to tell us about heart conditions, and it's going to tell us about upstream stenosis that may be present. Now, flow impedance is really telling us what's downstream from where we're at. So if I have an increased resistance from arterioles, maybe I have some arterial constriction for some reason, that is going to cause increased resistance. That is going to be shown more in this region in our early diastole. No resistance here, I'm going to get forward flow. If I have a lot of resistance, I'm going to get this early diastolic reversal. If I have major resistance, I am going to get I'm going to get that early diastolic reversal, and I won't return to forward motion until the next systole. That would be more resistant. We can refer to these waveforms as having three phases. So the systolic phase, the diastolic phase, the systolic phase, which would be right here, the early diastolic phase right here, and the late or end diastolic phase right here. So my systolic phase is telling me about the pressure and the ability to move blood forward. The early diastolic tells me if there's a little bit of, significant resistance, whereas the late diastolic is going to disappear and go below the baseline if there's a lot of resistance. Now, the other couple things, viscosity, like I said, it doesn't have that big of an impact on blood, but if somebody was really significantly compromised and they had a lot of viscosity, it could affect the flow impedance. And then inertia due to compliance or non-rigid vessels can occur. So if you have a 70-year smoker whose vessels are sclerosed, then they may not have that capacity for those vessels to be compliant to undergo the Windkessel effect, which we're going to talk about next. So the Windkessel effect is also known as the hydrostatic pump. This is where somebody with compliant vessels, so that gentleman I just talked about that maybe, has a lot of atherosclerosis, they're not going to have they're not going to have compliant vessels. So Windkessel would not help them out. But for most of our individuals, you're going to have the Windkessel effect or the hydrostatic pump that is able to help move that end diastolic flow forward again. And how it happens is it's just based off of potential energy. So as the left ventricle of the heart contracts and ejects that flow, you can see that our aorta is going to be expanded as that flow gets injected into the aorta. So as that aorta expands, it's going to take on that expansion like a potential difference. So as systole comes to an end, and the pressure within that aorta is less, the aorta is going to want to go back to its more neutral form, so it's going to contract back to its original state. And when it does that, that's when it's going to push that blood flow through in that second set of forward motion. So systole, diastole, it goes to a stop or even a reversal if there's resistance ahead. And then Windkessel says, okay, aorta goes back to its normal state, it's going to push blood flow forward again. Okay, this gets us to another rule called the rule of continuity, and this explains why blood does what it does, especially in a stenosis. So, because like all matter, blood cannot be created nor destroyed as it flows through a vessel. So, if I have a nice open vessel and then all of a sudden I come across a narrow stenosis, it says I have this much blood in here, and I cannot get rid of some just to make it comfortable to get through this stenosis. So in order to move more blood flow through an area or continue the movement of the same amount of blood flow, I'm going to have an increase in my velocity at a stenosis. So when you're trying to evaluate a stenosis, one of the things we do is we take a sample and we look at velocities within that stenosis, and that can give us a prediction of the percentage at which that stenosis is occluding the vessel. So it comes down to the law of continuity, or the continuity rule, where volumetric flow rate must be maintained despite a narrowing of the area. The volumetric flow rate is equal to the average flow speed across the vessel multiplied by the cross-sectional area. So in order to maintain the flow with a reduction of my cross-sectional area, I can only accomplish it by increasing the flow speed. Okay. Now, our bodies do a really great job of doing this for a long time, but there does eventually come the point where it cannot maintain enough lumen to get, even at really high speeds, to get enough blood through there to maintain the continuity rule. But it's pretty good at doing this for a great period of time. Okay, so like I just mentioned, so when we talked about Pucell's versus the law of continuity, when I mentioned Pucell's, I said that if we have a decrease in radius, we have a decrease in flow. And remember, the reason for that is that Pucell is talking about long straight tubes. So if I had a decrease in radius of my tube all the way, or of my vessel all the way, let's say of my aorta, from the root to the bifurcation, then of course I would have a decrease in flow. But if I have just a very small area with the stenosis, and then it goes back to its normal size, that is going to follow the law of continuity. So Pucell is going to be right if the reduction is through the whole tube, whereas the law of continuity is going to be right if we're just focused on one area of stenosis. Now, Bernoulli's effect also has an impact on blood flow. So this is something that's used many different places, the Bernoulli effect, including aeronautics and different things. But what we look at with the Bernoulli effect is that when we have an increase in velocity, the Bernoulli effect states that we're going to have a decrease in pressure. So if I know that at this stenosis here, I am going to have to, due to the law of continuity, I'm going to have to increase, or my blood's going to have to increase its velocity as it moves through that stenosis. Right at this point where it increases velocity, it is going to have a decrease in pressure, and that's due to the Bernoulli effect. So all of that talk about what is occurring in the body, it's wonderful. You guys deal with it every single day. For those of us that have to look at it through a machine and try and differentiate this, it's going to be important to understand a little bit about how the machine works. So when we're looking at how the machine and why the machine gets all this information, we can then, by understanding that, we can then optimize it and get better data for you to utilize in your patient care. So the Doppler effect is how we get the data in order to determine velocities and movement of blood and direction of flow and all of this. So the Doppler effect is really pretty simple. This is, I'm sure you all are aware, but this is how, police officers would detect your speed. And so what we do is we use sound, and we direct that sound towards a reflector. So in this case, towards your blood cells. So as if you've already taken the physics component of the point of care, you'll remember that ultrasound is always traveling in a frequency. And as I emit that sound wave to a moving object, it is going to crash in and interact with it. If that object is moving toward my sound wave, it is going to reflect that sound wave back with a higher frequency than the sound wave came in with. If it's moving away, that sound wave is like chasing it. When it does finally hit it, it is going to be reflected back with a lower frequency than it started with. So by seeing if I've had an increase or a positive change in my frequency, that will tell my machine that I have blood moving towards my transducer. If I have a decrease or a negative change in the frequency, that's going to tell that that object I hit was moving away from my transducer. But either way, a moving reflector will cause a shift in frequency, and that's what we call the Doppler shift. So as you can see, here's an example of, this gentleman listening over here. As the ambulance goes farther away from him, he's hearing less and less frequency as it moves away because it's going away. As it comes toward the other person, it's creating a higher and higher frequency sound because it's moving towards that frequency. The faster the reflector is moving, the more significant the change in frequency. And one other thing that we're going to look at that is going to affect on our ability to detect that change in frequency is the angle in which we're sending out the motion, or the initial frequency. So if I'm sending an initial frequency directly at the object, I'm going to get really good feedback. But if I'm kind of sending it at an obtuse angle from the object, I am not going to get as clear of a response. And so that's why when we're Dopplering or taking these samples, it's going to be really important to pay heed to what your angles are. So the Doppler shift, as I mentioned, that's simply the change in frequency caused by motion. So if I was using, say, a 5 megahertz transducer and my system recognized a returning echo that was 2 megahertz, I would know that I would have a -3 Doppler shift. So it's the difference from what was emitted to what returned. That's the Doppler shift. So if I had gone from 5 to 10, that would be a positive Doppler shift, and that would indicate movement toward the transducer. If I went from 5 to 2, that'd be a negative Doppler shift. That would indicate that the object was moving away from the transducer. Now, they can take these, and again, fortunately, our system is doing this behind the scenes, so we're not having to do these calculations. But once the Doppler shift is obtained, then our system can go in and it can actually calculate for velocity, which is what we're really interested in anyway. So to calculate velocity, what our equipment does is they calculate 77 centimeters per millisecond times the Doppler shift. So in our example, if we went from 5 to 2, this would be a -3. And then they divide that by the original operating frequency. So this would be our 5. Okay. So in this case, they could use 77 times 3 and then divide that by 5, and that would give it a negative, whatever the math is, Doppler shift. Okay. So that would say it was going at a negative velocity away from me. Now, the place that they get this 77 centimeters per millisecond to plug into this equation, just in case you're interested, comes from the sound propagation speed through the body. So it's just a derivation from that value. Okay, so sonographic instruments measure Doppler shifts. Doppler shifts are then put into the calculations, and they allow us to determine velocities. Velocities help determine if there's any sort of changes in resistance or in area of vessels, which helps us determine what percentage of stenosis may be occurring in a vessel. The lowest detectable shifts are within just a few millimeters per second. So it's pretty good at picking up very low shifts. And that would be important because low shifts would come from very low, slow moving objects. So the ability to pick up very low flow, slow flow comes in really handy when we're looking at, say, ovaries or testicles for torsion. So it's pretty good at picking up low flow, although we have power Doppler we're going to talk about in a minute, which can be even better for that. Okay, now we talked in the beginning of the lecture about how angle had an impact on calculating the Doppler shift and the speed, and basically just getting the sound wave into the vessel. So it's important that as practitioners, if you're ever going to be evaluating flow for velocity, that you understand angle correction. If you're just doing a venous flow, if you're just doing like looking to see is there flow present, yes or no, angle correction is not going to be that important. But if you are looking for a velocity, you absolutely have to follow appropriate angle corrections technique. So Doppler shift will be optimized at certain angles. And I showed you when we had our little picture of the ambulance, or if you've ever been in an accident, probably the accident you want to avoid the most is going to be a head-on collision. That is going to have the most significant crash and impact. Because it has the most significant crash or impact, it's going to have the most significant change in frequency or Doppler shift, and it's going to give the purest information so that it can be calculated into that velocity calculator. So at 0 degrees, we can get optimal Doppler shift. Now, because of how the human body is organized, it's pretty difficult to get 0 degrees in a lot of our vessels. So because that's unrealistic, most of the time we're not going to get 0 degrees. Well, if we can't get 0 degrees, our next degrees that we need to shoot for is 30 to 60 degrees. The reason for this is the Doppler shift is based on the cosine. So they're going to calculate a cosine into our Doppler shift velocity calculations, which is going to accommodate for non-perpendicular interactions. So it knows that most of the time I'm going to be not perpendicular to my vessel, and that is going to affect the impact of my Doppler shift. And so in order to address that inaccuracy, they're going to apply a cosine for the angle that I'm at, which should correct the deviance that I would have gotten at 0 degrees. Now, anytime, if you look at our cosines for various angles, anything after 60, at 60, we're at about a cosine of 0.5. After that, our cosines get very inaccurate, and so we're not allowed to use a Doppler angle greater than 60. We're also not allowed to use, or we're discouraged from using, a Doppler angle of less than 30, because what happens with the Doppler angle of less than 30, oftentimes the sound wave will come in and it will basically kind of skip off of the vessel like skipping a rock. And so the data from that less than 30 is going to be not very accurate. So we kind of have this sweet spot here where 0 is our best, but if we can't get 0, we want to go from 30 to 60. Now, when I talk about what the Doppler angle is, when we looked at the vessel originally, the vessel, there was an image of a vessel being scanned, and we talked about the sample being set in that vessel. The Doppler angle is represented with a long line through the center of that sample. So this long line, that is going to be our Doppler angle. We need to make that Doppler angle, like we're going to talk about more here in a second, but we need to make that Doppler angle parallel to our vessel wall and in the center where we're not going to be affected by any of that friction flow. So our Doppler angle has to be at 0 or 30 to 60, and that's going to be read out on our screen. And so once we add in that angle information, we will find that our velocities become much more accurate by incorporating that cosine into that Doppler shift calculation for velocity that we already talked about. So if you look at why this is so important, so here we see a vessel, a little bit oblique across the screen, which is just fine. And we see that this right here is our Doppler angle, and our Doppler angle is read on the screen as 40. So that would be an appropriate Doppler angle. The angle is parallel to the wall, so that is good. And it's giving us a peak systolic velocity. So at the top of systole, we're getting a peak systolic velocity of about 84 with an end diastolic velocity of about 23. Now, as I go up to 50, my velocity by still maintaining all good practices, parallel angle to the wall, 50 degrees, that's under 60, my velocity goes up to 107. If I go right at 60, my velocity goes up to 116. All of these would be acceptable. They're within about, let's see, 30 centimeters per second. But you see, as we go all the way up to 70, which is well out of the range, my velocity is now 123. Oh, excuse me, I'm sorry, I'm wrong one here. It's 144, which is well out of the acceptable range of error. So you also see that the waveform starts to change. So they've just made the rules. I mean, the rules are intact that it should be 0 or 30 to 60 because our velocities get more and more inaccurate if we go over 60. Okay. Color Doppler. So color Doppler is using the same thing that we just looked at. The images that we looked at showing the waveforms, those were spectral Doppler. Now we're going to talk about color Doppler. So color Doppler is still using Doppler shifts, and then it's applying a color for the velocities that it detected. So color Doppler represents real-time motion along with grayscale anatomic imaging. So what's happening here is your machine is producing just your basic B-mode grayscale image, and then it's overlaying the color flow on top. So it's looking for those Doppler shifts. It's taking that Doppler shift information, it's plugging it into those velocity equations, and then it's determining how fast and what direction the blood flow is going. In this case, it shows that I have red above the line and blue below the line. That would indicate that anything that is red is moving towards my transducer. Anything that is blue is moving away from my transducer. Now, the hue or the color, as you can see, as it's closer to the baseline or 0, it's bright red. As it gets farther away, which means it's moving faster, it gets more of this yellow hue. Same thing on the blue end. So with my color here, I am not only detecting that there's motion, yes there is, because I have color, I'm detecting the direction of the motion by whether it's red or blue, and I'm detecting a general velocity of the motion by the hue of its color. So I'm getting a lot of information here. So utilizing that color Doppler can be good to detect like the blood flow, as I mentioned, the direction and the velocity. Now, it's not going to be as accurate on velocity as, say, our spectral that we were just looking at, but it is still, it gives us an indication. Let's see, if an echo demonstrates a Doppler shift, it is assigned a color by the operator. So in this case, let's say I said, oh, I don't really like this, maybe, well, this isn't, I don't really like this vessel being shown as red because I feel like it's a venous vessel. I have the ability to do something just called invert, where if you press the invert button on your equipment, it will flip red to bottom, blue to top. It's just important that you're aware as the operator that you can do that. The machine has no way to determine something's arterial or venous. So it's a misconception to believe that all arterial is red and all venous is blue. Basically, we have to make the color scale correlate to the red and blue that we want to see on our image. The other thing is that we can get tissue shifts as well. So if you see, like maybe you're looking near the heart and the heart is moving and it's detecting the heart with color because the tissue is moving, but you don't want to see that because you are concentrating on the blood flow. In that case, there's a setting on your equipment that is called a wall filter. And by turning up the wall filter, it's going to try and filter out some of the color, which is motion from tissue. And so that you can then concentrate on your just blood flow. Okay, the other thing is where we talked about angle being very important. The worst angle to use is 90 degrees. So at 90 degrees, you get essentially no feedback. So here you see this is a transducer getting perpendicular incidence to the vessel, meaning the sound waves are coming in at 90 degrees to the vessel. And at 90 degrees to the vessel wall is basically reflecting all of the sound waves back towards the transducer before it gets into the vessel. And so at what we call perpendicular 90-degree incidence, you will not get any Doppler shift and you'll have very poor color flow. Now, sometimes you might want to have a vessel perpendicular because you're looking inside the walls very clearly, as you can see here, but you don't want to have it affect the color in this manner. So one of the things that you can do is utilize a color box, which you see here, and you can steer your color box one direction or the other so that the sound wave is coming in aligned with that color box. So your vessel's still perpendicular to the screen, but because you've angled your color box, the sound waves are coming in at an angle and therefore able to better penetrate that vessel and get you the information that you need. Now, all of these little techniques of optimizing your color, this is something that we can do hands-on when we do your individual meetings with your equipment. So if it doesn't make a lot of sense right now, just try and kind of retain it until you get your hands on or start playing with any equipment you might have on site. Okay, now just as the operator can adjust which color goes on top, which color goes on bottom, the other thing that we have to look at with our color mapping is a baseline, which is basically our 0 point. Anything above the baseline is going to be red in this case. Anything below the baseline is going to be blue. Now, the other thing that will happen is this is partially determined by what we call the Nyquist limit. This basically is the limit at which, on a very simple explanation, it's the limit at which if I have a velocity that goes over whatever my scale is, say in this case it's 13, if I have a velocity going 50, there would be no red hue to represent that velocity. And so it would do what we call wraparound or alias, and it would start demonstrating any velocity going faster than 13 as blue. So we call that aliasing, where you have a velocity, like in this case, that's probably much higher than 13, but because there's not the scale to represent it, it's aliasing and turning it blue. So as an operator, you would then need to be able to identify that that was occurring and increase your scale until this velocity was, say, in our previous example, 60, so that it could represent all the way up past that 54 centimeters per second. Okay. So if it passes the Nyquist limit, we get aliasing. We address that by adjusting our scale upward. And we do have some other basic color controls, so we'll go over those relatively quickly here. So color gain just means turning it up or turning it down. Just like in B mode or black and white imaging, if I turn the gain up, my whole image becomes brighter. Same thing with color. If I have an image I'm not getting great color on, then I can turn it up and the color is going to become more sensitive. I can also move the color window. So this here in my green, that's my color window. We talked about how it can be steered. There'll be a setting on your equipment where you can steer that color window. You can also narrow it. You can make it taller. You can make it smaller or bigger. You can move it up and down, and so that you get all or limit it to the vessels that you want. Now, one thing about your color window, you usually want to keep it relatively confined. You don't want a lot of information in it that doesn't have to be there, because it's going to slow down your frame rate and make that more challenging the bigger and bigger it gets. You can steer the angle, like I said, of that window. You can do color map inversion, like I talked about. Here you see the tech or the operator has it all set, so red on top, blue on bottom. But if you so wished, you could do an inversion, have blue on top, red on bottom, and that would mean blue was towards, red was away. You can see in this example here, we just talked about scale. This would be an incident where I have velocities that are going faster than the velocities I've accommodated for here on my scale. So I would need to increase my scale, and you see they're doing that here. They're increasing their scale till I no longer have that aliasing or blue effect. I also mentioned a little bit ago wall filter. So because color is going to be shown anywhere that there is motion, if I am struggling with either, maybe in this case, it's like a carotid, maybe I have some pulsatility in that carotid artery that's distracting me or showing bleeding of the color out into the wall, I can increase my wall filter or turn down my gain to help eliminate that color. The baseline shift we don't use so much with color. It would basically shift the 0 point up or down. Where we end up using it a lot is here when you look on the spectral side. If you have a spectral image that's getting cut off or that it's showing aliasing, then by increasing or by moving your baseline up or down, you can bring that all into the screen. Okay, so color Doppler can be fantastic. It demonstrates blood flow. It determines the direction of your flow. It can even demonstrate, sometimes to our benefit, sometimes to our detriment, but it can demonstrate non-vascular motion like urethral jets in the bladder. Other times those can be distracting when it's wall motion or heart motion or something like that. It does have some limitations because we have to be very, very careful with our angles. It does lower our frame rate, like I said, so your system might start feeling like it's bogged down. And it does have a lack of detailed spectral information. Spectral really referring to not just showing direction of flow, but the velocity of flow. So in order to, have additional opportunities to show those things, we have some additional settings. One of the challenges that if you haven't been scanning a lot of vascular, that you can encounter is that you see something like this, where you see this split of red and blue, and you're trying to decide, do I have aliasing here, or do I really have red going one direction and blue going the other? In this particular case, this is an aortic aneurysm, so this would show a dilatation of the aorta, which the red is coming down because of the dilatation. There's some turbulence, and it's kind of swirling in here like a dishwasher, and then it's going to turn and go back down. So this is actually a true separation of flow. So this would be accurately showing. This would be showing accurate information. Now, if we compare that over here, we can see that all the blood really should be flowing the correct way, and yet I am getting these hues in areas where I probably have increased speeds. So in this case, that's something I would need to increase my scale to get a reduction in aliasing. Now, this one here, this is showing inaccurate information because I have an angle less than 30 degrees, and my angle is not parallel to my vessel wall. So this would be probably another indication of some aliasing. Okay, now I said that our color Doppler was not perfect, and so we have some other strategies to help when our color Doppler is not helping us. So we have something called power Doppler. Sometimes this is called color power Doppler. It just depends on who the manufacturer of your equipment is as to what they call this, this imaging strategy. But basically it represents two-dimensional color information, and rather than measuring the strength and the direction of the Doppler shifts, it looks at the intensity of the Doppler shifts. So if it gets lots and lots and lots of movement in one area, it's going to demonstrate that as a brighter hue. So, and it does not show direction at all. So it shows the concentration of moving reflectors. This is much more sensitive than color. So as sonographers, we use this all the time in areas where color is a little bit hard to detect, like the ovary when we're scanning it transabdominally, or maybe like the testes or something like that. So it's not angle dependent. It's better sensitivity than our traditional color flow, but we lose our directional information. So, and you can see that here. Here in our traditional color flow at the area that they're getting 90-degree incidence, they have no flow because it's angle dependent. But here with our power Doppler, they're getting flow despite the angle. So again, a little bit more sensitive, pretty user-friendly in some situations. That brings us to spectral Doppler. So spectral Doppler is basically, it is this display of the waveform. So it's our visual representation of how blood is moving through the system. We have two different options for spectral Doppler, and continuous wave is usually only used in echo, is for the most part, or some more intricate vascular imaging, but pulse wave is going to be used very, very frequently. So this is probably where most of our focus is going to be. Continuous wave is just what it says it is. You're sending out a wave of sound continuously. It's interacting, it's coming back and being received by a receiver on that same transducer. Pulse wave, we do a lot of other fancy things and able to steer our beam and get an image while we're getting color over the top of it, while we're taking a spectral analysis. So it allows us to do a lot more things. Now, continuous wave is going to be the most sensitive for velocity peaks. That's why it's used typically, like if you're doing an echo and you have somebody with a severe aortic stenosis, you might use continuous wave to just see what those velocity peaks are to determine how severe that stenosis is. But for the most part, we're going to be using all the tools we have with pulse wave to evaluate our vessels. That way, with the help of being able to visualize the level we're looking at, place our gate, all of those specifics. So spectral analysis, we've looked at a lot of these, but we haven't really talked about what they are. So what spectral analysis, when I first started learning about these, I thought of them as like one thing. Like, oh, it's like one blood cell moving through this root system. What's really happening is when I have my vessel and I have my sample site here and I have my angle just perfect, we know that blood is moving through this sample. And when blood is moving through the sample, it's not all typically going to be going at exactly the same velocity. So for every moment in time, it's taking a velocity measurement across this area. And that velocity measurement is going to have some varying velocities within it. So at that moment in time, it takes its measurement and it's going to come over here and it's going to draw a line from the maximum velocity to the minimum velocity taken at that moment. The next moment, more blood comes through and it's going to take that measurement and draw a line from the maximum to the minimum. So here you see that the velocities, let's say in this sample over here, are from about 80 to 40. Say 80 to 40. So at this moment in time, passing through this sample, I had a range of velocities from 40 to 80. Now, if we go over here and we look, and I know I'm cutting this off a little bit, but we have 160 is my peak here. At this particular moment in time within that sample, it picked up velocities ranging from actually negative something, so going reversed, to positive 160. So this would tell me that I have forward motion up to a really high velocity, but I also have some reversal. So this is probably a very turbulent area. I have all kinds of velocities going on at this one moment in time. So as it does that, it's drawing these lines each time it gets a sample. And overall, those lines will then kind of create the ultimate pattern as what's happening and give us our spectral analysis. Now, some of the things that we can really measure off of our spectral analysis is often the peak systole. So we measure peak systole right here and end diastole. And this would be able to allow us to look at resistive index, systolic to diastolic ratios, a number of different things. Now, we just set the cursors, and then our computer can do those calculations as to what our velocities are. So if I look at this waveform, there's a couple things I can note on it. First of all, I'm going to say I have a swift systolic upstroke. That means that I have a pretty good pressure moving that blood flow forward. And then I have an early diastole. It's going to drop off, and yet I never lose forward motion. It always is staying above the baseline, and it's continuing above the baseline all the way through end diastole. So in this particular case, I'm going to call this a biphasic, meaning two phases. It's got a systolic phase and a diastolic phase. Biphasic, low resistance waveform, because in order to get this waveform with no stopping and no reversal in early diastole, there's really no limited resistance up ahead. So this would be low resistance biphasic waveform. The other thing I can note about this is that it has what we call an open envelope. So this area here where there's no information, that's referred to as the envelope. If there's turbulence, I'm going to have forward motion, backward motion, slow and fast all in one, and it fills in the entirety of the scale. So this I'm going to call spectral broadening, because the spectrum broadens and fills in all the information. And this, I'm going to say, has an open envelope. So this open envelope would indicate that I have no major turbulence. Okay, now if I look here, I see that it's actually, in general, a pretty similar waveform. I've got pretty good systolic upstroke, a little bit of a notch through diastole, meaning there's a little bit of hesitation there, but then I have good forward motion all the way through diastole. So this again is very low resistance waveform, but I do see a wider spectral pattern. I have some spectral broadening here. Now, what this could indicate is that I actually opened up my sample size and I'm including more peripheral information as well. And remember, that blood is going to be moving slower in the periphery than it will be centrally. And so I would get some lowered velocities. Therefore, I would go from lower to higher velocity, and that could account for my spectral broadening. Okay. So this again, low velocity spectral broadening. Now here, I have some other things going on. So if you look here, how this line is kind of gradual. It's certainly not a sharp systolic upstroke like I saw over here. It's a gradual line. This is indicative of what we call tardus parvus, being tardy, right? So rather than a quick systolic upstroke, it's going to have a late slow upstroke. So this would indicate that this is probably a signal that is maybe post-stenosis. So let's say I had a narrowing here, and despite my vessel's best efforts to move as much blood flow through here as it could to maintain that law of continuity, it was unable to do so. So I have blood get through this stenosis. Now I have a decrease in pressure because I've lost some of my blood pressure back here. So I have this decrease in pressure causing tardus parvus. Okay. Now I have less blood here than I had here, and I have vessels down here that still want to be fed, so they're going to have a very low resistance. So my blood flow is going to continue forward flow through easily to that tissue bed. Low resistance because of the decrease in blood volume or pressure in this post-stenotic area. And then finally, I am seeing forward flow of blood and backward flow of blood, and all velocities in between, indicating that this is a turbulent area. So this would be pretty indicative of a post-stenotic tardus parvus low resistance waveform. Okay. So just kind of some different terminology you're going to be thinking about. But when I'm trying to teach ultrasound students about this, I'm always telling them, be the red blood cell, be the blood cell. So when the heart squeezes, it's going to project you forward. When the heart stops squeezing, you get to slow down. If there's nothing ahead of you, you get to go ahead and continue slowly on your way forward. Okay. In this particular case, the heart squeezes, but there's not much pressure behind you, so you kind of meander forward. As it stops squeezing, you kind of slow down, but you got no resistance ahead, so you kind of just wander forward. But you've got some people in your party that didn't push forward through enough, and they start winding around here in a turbulent state, and that's when we get them below the baseline. So big terminology there would be envelope, spectral broadening, tardus parvus, and then looking for that turbulence. Okay, so I pretty much covered all of this in that last slide, but one thing we haven't looked at much was venous, and then a couple little notes off this slide. So we did look at that biphasic waveform in the last example. Now this one, you're going to see fast systolic upstroke, so that means I have good pressure behind me. Early diastolic, I'm going to go all the way to a stop, and then I have pressure ahead of me pushing me back, and then Wind-Kessel effect pushes me forward. So I'm going to call this a triphasic waveform. 1, 2, 3. So phase 1 tells me that I have good pressure behind me. Phase 2 tells me that I have significant resistance in front of me. But phase 3 tells me that my vessels are compliant and able to have that Wind-Kessel effect enough to squeeze that blood flow forward, and so it's not so resistant that I can't have any motion. So this would be a triphasic moderate resistance waveform. It has good spectral envelope, meaning that I probably did a great job with my angle and my placement of my sample. Most of our systems are going to display about 100 to 1,000 little lines per second. The horizontal line is time, so this is over time, and then the vertical axis is going to be velocity. Positive shifts are going to be usually demonstrated above the line. Negative shifts or reversals are going to be below the line, but recognize this too can be inverted by the operator, so make sure that you're doing that intentionally to make it correct. Now, this is an example of a venous waveform. So, like we talked about originally, venous waveforms aren't controlled by the heart pump. They're really controlled by pressure gradients. And so, in this particular case, you can see that there's forward blood motion, it stops, and it reverses. Now, most of the time in our venous system, we're hoping our blood doesn't reverse very much because that would probably indicate that there's some faulty valves. But in this particular case, you're seeing that forward and that reversed movement. Some of that can have to do with just the patient breathing, but we call this a phasic waveform. It moves with our respiratory phases, not with this pulsatility that our arterial side is gonna move with. And as we get more into our venous content, we'll talk exactly how to kind of manipulate and evaluate that venous flow more. We already pretty much talked about spectral broadening. So this is usually caused by turbulent or disturbed flow. But if you know that you don't have any turbulent flow and you're still seeing an issue with spectral broadening, you could have poor sample position, meaning it's too close to the wall or it's too large, or you could be using an inadequate angle. So remember, 0 or 30 to 60. All right, we're almost to the end here, so I'll try and make this quick, and we talked about some of this already, but we know that our waveform at a particular area can really not just tell us what's happening at that area, but what's happening proximal to it or distal to it. And so some of the examples that you'll see here is, here's a pretty normal looking waveform. I would say that this is relatively low resistance. So we have a good systolic upstroke, little bit of a dip here in early diastole, but very low resistance because it continues to move forward through all of diastole. Now, if there's a stenosis downstream, that's going to, and it's not able to move blood flow through, it's going to almost act like an arterial constriction. It's going to increase the resistance to the blood coming into it. So here you still see good systolic upstroke, but you see this, the early diastole, the forward motion is reduced in early diastole. Late diastole, Wind-Kessel is still strong enough to push it through. So that's saying that it's not totally occluded, it's not a huge resistance, but something's ahead. Now, if this were seen in a high resistance tissue bed like the muscle, I might not think much of it, but if I'm seeing something like this in the liver or kidneys or something of that nature, then that would be, concerning. Now here, once you get into the stenosis, you can still, the waveform in the stenosis is going to look pretty much as normal. So you still see good systolic upstroke. you're in the stenosis now, so you don't have anything ahead of you. You're already in it that would cause resistance. So you're going to see more of a normal waveform where you get this little dip in the early diastole, then it moves forward through the rest of diastole. But what's going to change here is in the stenosis is you're going to have that increase in velocity. So you're going to have your velocity peak here in stenosis with that reduction in pressure. So that's how you can see kind of as if, say, you're scanning down a vessel and you're seeing your waveform change, it's going to kind of tell you what's ahead. Now, most of the time you might think that doesn't even matter. Why would I care what's ahead if I'm going to see it anyway? But sometimes you'll get to parts of the body where you're just not able to see a certain area of a vessel, maybe because it's under bone or something else. And so these indicators can be lifesavers in finding these issues when you can't see in a particular area. Here's just another example. We kind of looked at the tardus parvus. This would be a post-stenosis waveform. So we see that decrease in pressure post-stenosis. So we have a slower systole and then very low resistance and then some spectral broadening typically. And that's just because we have no pressure pushing it forward. And despite my body's best efforts, it doesn't have enough blood flow in that region past the stenosis to feed the tissue bed. So that tissue is going to be wanting more blood flow and is going to be accepting blood flow easy throughout all of diastole, excuse me. Okay, so that is it for today. If you have any questions or need clarification on anything, please let me know. It was just kind of a bit of an introduction today, but we'll delve into some more in-depth information next week. So thank you so much for joining me. Please read through the summary notes and let me know if I can be of any assistance. Thanks for being here.